Hello, good afternoon. Starting off this afternoon of presentations with a set of presentations about training therapists and how one trains therapists and outcomes related to training therapists. And so I'm going to tell you about how I've implemented and run a DBT clinic for borderline personality disorder in my training setting at Rutgers. I probably don't need to tell this audience that DBT has broad empirical support across multiple populations and settings, yet there is really very little known about best practices to train clinicians in DBT, and it's also unclear to what extent students in training can achieve good outcomes in DBT. In other words, can somebody who is new to DBT successfully treat clients, or do they need to have a certain level of experience before their treatment can be successful? And a corollary of that is, can clients with severe and chronic problems be successfully treated by trainees? I don't know what your training setting is like, but I know in most training settings that I've been familiar with, there's constantly debate about whether a person who's in training can see somebody who's severe, or whether you need to refer severe folks to more senior clinicians. And so trying to determine, can we treat more severe clients with students in training successfully? Linehan and two of her students in 2012 published some guidelines for DBT training clinics, in which she said that any solid DBT training clinic should have didactic components, which include academic seminars, as well as opportunities for students themselves to teach about DBT as a way of kind of learning the treatment themselves, and that the clinical practicum involved should make sure that students have involvement in all modes of DBT: individual therapy, skills training, phone coaching, as well as consultation team, and that, of course, these students be supervised by a DBT expert. So the aim of this study is to evaluate the effectiveness of a DBT training clinic that we refer to as DBT-RU, DBT Rutgers University. So we looked at the effectiveness of the training clinic over its first 5 years in operation. All the therapists and assessors are graduate students, doctoral students. All the clients meet criteria for borderline personality disorder. And in this clinic, we provide 6 months of standard DBT, sort of by-the-book DBT. The therapists and assessors in our clinic for this study was comprised of 15 advanced graduate students in our clinical psychology doctoral programs. A couple of them are here today. The therapists, you can see, were predominantly female, 2/3 Caucasian, and young, mid to late 20s. In terms of training, the therapists all, prior to being in the practicum, completed a semester-long DBT course that I taught. They were then accepted into the DBT practicum, in which they were to attend weekly DBT consultation meetings, a weekly hour of didactics. When they started in the training program, they were also participated in another student's weekly individual supervision, so learning the treatment via watching another person's supervision. And then when they had their own client, or when they started doing group, they also received weekly individual supervision. A subset of this group were also invited to attend a 2-week intensive DBT training. The clients in this program, here are the inclusion criteria. They were adults, all of whom met criteria for BPD and lived within 45 minutes of our clinic. This is a research clinic, and so they had to consent to research procedures, as well as willing to pay a sliding scale fee. But when I say sliding scale, I mean sliding scale, because most of our participants probably paid $10 a week. And a subset of the participants were part of another study funded by the American Foundation for Suicide Prevention, and so the subset had to have a repeated history of suicide attempts or non-suicidal self-injury. The other clinic group could have had suicide attempts or non-suicidal self-injury, it's just that they weren't required to have it. And then you could see our exclusion criteria. We actually exclude for very few reasons. In terms of what we ended up with for participants, we had 50 individuals, 40 of whom were female, close to 30 years on average, and 2/3 Caucasian. Here are some demographic factors. I think probably what's most notable is that about half the sample unemployed, at least at baseline. Pretty typical of a treatment program for borderline personality disorder. They met a number of comorbid conditions at baseline, so close to 3 current Axis 1 disorders and 1 to 2 other Axis 2 disorders. And here you can see some of the most common Axis 1 and Axis 2 disorders. Again, I don't think this is probably much different than what you see. And we had quite a range in terms of suicidal behavior at baseline. Lifetime suicide attempts, the median number was 2. Lifetime non-suicidal self-injurious acts, the median was 22 at baseline. In terms of our procedures, all participants were self-referred or referred by local agencies. They called our clinic and were screened over the phone. If they appeared to be eligible based on the phone screen, they were invited in for an intake assessment in which they gave informed consent and participated in diagnostic interviews and baseline measures. And then we also did a mid-treatment at 3 months and a post-treatment assessment. And again, the assessments were conducted by clinical psychology grad students under my supervision. The treatment was 6 months of comprehensive DBT. If you're not that familiar, this is what it entailed: weekly individual therapy, weekly group skills training, as-needed phone coaching, and a weekly consultation team. As a standard in DBT, we define dropout as having, if you miss 4 consecutive sessions of either individual or group skills training. And here are the interviews that we gave. We switched the measure that we used for suicidal behaviors kind of halfway through. So half had the suicide attempt self-injury interview, and half had the self-injurious thoughts and behaviors interview. And here are the notable self-reports that we used. I want to skip to showing you the data. So the results: of the 50 individuals, 2/3 of them completed the 6 months of treatment, and 1/3 were considered dropouts. There were no significant differences between completers and dropouts on any demographic variables or baseline psychopathology variables, so there didn't appear to be differences in terms of severity as to whether they stayed in treatment or dropped out. And then we attempted to get people who dropped out of treatment to continue to come in for assessments, but I'm guessing this is true for most of you. That's fairly difficult. Of our completers, we had everyone participate in all of their assessments, but the dropouts was more mixed. This is just to show that on average, all participants had about 19 individual sessions and attended 15 skills group over the 6-month period. Obviously, that differed by completers versus dropouts. In terms of suicidal behavior, what we did here was looked at how did their treatment behavior compare to the 6 months prior to treatment, since the treatment was a 6-month period of time. 6 months prior to treatment, this is number of individuals, sorry, that there were 15 individuals who had made a suicide attempt. During treatment, 5 made a suicide attempt. 26 of the 50 had engaged in non-suicidal self-injury in the 6 months prior to treatment, and 14 of those during the 6 months treatment. But if you only look at the last 3 months of treatment, there were 2 suicide attempts and 2 individuals with suicide attempts and 9 individuals with non-suicidal self-injury. So it seemed to go down over time in treatment. This is using the self-report measures. Obviously, this is a lot of information all on one page, but what you see is that there are significant reductions across all measures in severity, and these were large effect sizes. Now, of course, the issue is that this is a not controlled sample of 50 participants, and so in order to determine, how does this compare to other people in treatment, even though we ourselves don't have a control condition, we compared the results using benchmarking analysis to McMain and colleagues' 2012 study comparing DBT to general psychiatric management. And we looked at symptom change in primary and secondary outcomes by comparing effect sizes of pre-post symptom changes of comparable constructs. So we didn't use exactly the same measures, but if they were similar constructs, we could look at changes in effect sizes. So for example, we looked at borderline personality disorder symptoms using the BSL-23. McMain used the ZAN BPD measure, but what we found was that we had a large effect size in terms of BPD symptoms reducing over time, and McMain had a large effect size. In terms of global pathology, we also had a large effect size and reduction of global severity index on the BSI, sorry, and that compared to a medium effect size of global pathology in the McMain study. And depression, both our clinic and the McMain study had a large effect size in terms of reduction of depression. So now what about whether changes were clinically significant and reliable? And here we use the method proposed by Wise in 2004 and looked at the integration of both the reliable change index as well as measures of clinical significance to see whether the changes that we found were clinically significant and reliable. According to the WISE definition, looking across these 4 different measures for which we could examine this, what you see is approximately, it kind of changes depending on which measure you're looking at. According to this, 1/3 of the sample would be considered recovered at the end of 6 months based on borderline symptom the borderline symptom list. 1/3 would be recovered based on the DERS, and then less would be recovered based on the BDI and the global severity index. And then a larger percentage showed a positive response, and then you could see how many had a minimal positive response, and then about 1/4 overall would be classified as not responding. Okay. So in terms of conclusions, I think what we could say is that DBT seems feasible to implement in a training clinic and appears to be effective. There were significant changes over time, that there was similar effect sizes to the McMain study, and that most experienced a positive symptom change. There's some limitations, which is that this was a 6-month study comparison to a 12-month study where most of the research on DBT has used a 12-month research trial. And the other kind of major limitation is that adherence ratings were not obtained for this study, so we don't know how well our therapists are doing compared to adherence ratings in other studies. In terms of implementation considerations for any of you that are running a DBT training clinic, or probably any training clinic for borderline personality disorder, you know that it takes a lot of time for the person who's running the clinic. It's a lot of supervision, a lot of oversight. There are some phone calls in the off hours about crisis calls, et cetera. It's difficult to find expert supervisors, so these would be other expert DBT clinicians in the area who are willing to supervise a doctoral student for free. So that is difficult, as you might imagine. It's also a time-intensive experience for students, and so students, I think, on average, will report that they really value the clinical training and the types of clients that they see in this training experience, but compared to other training experiences, they don't get to document hundreds of hours. The number of hours spent in direct consultation with clients is fewer. Also, sustainability for any training clinic, I think, is an issue that I stay the same, but my students change every year. And so we have to start from the beginning, from scratch every year. On the flip side of that, trainees are malleable and are actually receptive to feedback and will do things that you ask them to do, which is not always the case when you're supervising more advanced people. So I have found that to be a more positive experience. And also, obviously, it's highly cost-effective to do this because the students work for free. So I just wanted to end by saying that this project was partially supported by the American Foundation for Suicide Prevention, and to say thanks to the entire DBT RU team and Carrie Diamond, who served as a supervisor. Thank you. Other questions? Oh, yes. Yeah.
Could we say that the 6-month treatment is a finding and not a limitation? And that it may not be necessary to take 12 months to treat the patient?
That's a good question. So the question is, can the 6 months be seen as it actually doesn't take that long, and that it could be an advantage to have it be a 6-month treatment? Certainly something that we want to explore further. I think other studies that have looked at 12 months of DBT have shown that the most change occurs, at least in terms of the life-threatening behaviors like suicide attempts and non-suicidal self-injury, occurs within the first 6 months of treatment. And so I think that there is a subset of individuals who, at the end of 6 months, are sufficiently treated. But then there's also a subset that I think could use more time. And so the limitation is that we didn't have flexibility with that. Any other questions? Okay, thanks.